Bismillahirrahmanirrahim. رب اشرح لي ويسر لي امري واحلل عقدة من لساني يفقهوا قولي. Assalamu alaikum everyone. My seniors, my juniors, my colleagues of dermatology and other faculties also. Today we are going to discuss two cases of purely dermatological problems, but they were treated and they improved and they give very good results with aesthetic procedure, supposed to be aesthetic procedure. It is a common perception that some procedures are reserved for aesthetic purposes, but they are not actually purely aesthetic. So they work very well in pure dermatology. And the reason of presenting these two cases is only to introduce or to be useful to these procedures in pure dermatological cases, because there are a variety of indications of this particular aesthetic procedure in dermatology. Now, I would like to invite Dr. Medina Farhan. She is the assistant professor of dermatology over here to present the cases. Thank you.
Thank you, Professor Mera. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Using this prestigious platform of CPC, I would like to present two cases which were treated here, one in OPD and the other one as an indoor patient in our hospital. And both were, as ma'am pointed out earlier, that both were cases of clinical dermatology, but they were treated with an aesthetic procedure. Let's start with our first case. So our first case was of a 30-year-old male with no previously known comorbids, and he was resident of Bellary. Bellary is a small place, a remote area in interior Sindh, and he was a security guard by profession. And he presented to us with slowly growing painless ulcer on the right shin for the last 6 months. According to the patient, he was in his usual state about around like 6 months back when he developed an asymptomatic nodule, small nodule which gradually increased in size, gradually and progressively during the last 6 months, and eventually it ulcerated and it got super infected. And it was not associated with any kind of constitutional symptoms, but it was accompanied by off and on oozing and purulent discharge. Now, as he resided in a remote area, he went to several doctors. He prescribed him different kinds of topical and systemic antibiotics, and which showed no response. On the contrary, the lesion increased and worsened. And ultimately, he went to a dermatologist, a fellow worthy dermatologist, who made a provisional diagnosis of cutaneous leishmaniasis clinically, and referred him to us as we are in a tertiary care hospital, and he wanted him to be managed as an indoor patient. Now, when he presented to us and we examined him, there was a circular ulcer, 5 by 5 centimeter, with raised indurated margins and vesiculation on the margins as well, whereas the floor, it contained granulation tissue along with pus and blood. Clinically, it favored cutaneous leishmaniasis, as there was as it was totally symptomatic. There was no itching, there was no pain during the past 6 months, and even when there was pus and there was evidence of superimposed bacterial infection, there was no surrounding cellulitis, there was no surrounding edema, and there was no pain at all. So we decided to manage him on the lines of cutaneous leishmaniasis, but prior to starting the treatment, we sent a skin biopsy and for histopathology. And the baseline labs, they were all normal, including the hepatitis profile. The skin biopsy was sent, and then we made some differential diagnosis. The first one was cutaneous leishmaniasis, then squamous cell carcinoma, basal cell carcinoma, and a bacterial infection, actinic gangrenosom. We carried on with the oral and topical antibiotics. Unfortunately, we don't have the many of the lab reports available at the moment, but we also sent a pus for culture, and according to that, we started with oral and topical antibiotics as well. But there was no response during his indoor stay. Moreover, the floor of the ulcer it gradually got covered with thick necrotic crust. The lesion increased in size, and so While the biopsy report was awaited, we decided to place him on anti-leishmanial treatment, that is injection glucantime, according to his body weight, 20 mg per kg, and it was to be continued for 14 days. It was administered intramuscularly as well as intralesionally. We took some pictures on the third day of glucantime, and after the 7th dose, and after the 10th dose. And as you can see, despite the ongoing antibiotics and antimalarial treatments, the ulcer it showed no signs of healing and it had still had active margins. The necrotic crust it was cleaned multiple times, only to reveal purulent base and oozing ulcer, and it was fresh. There were no signs of um, any evident healing or response to the treatment. Now, when the histopathology report arrived, it was totally inconclusive and it showed very non-specific findings of acute eczematous dermatitis, which did not correlate with our clinical, with the clinical picture of the patient at all. And so we decided to proceed on the lines of management of a non-healing ulcer. So we did our research and we discussed the case, and then we planned sessions of platelet-rich plasma. And we did our first session of platelet-rich plasma. We injected it along the margins of the ulcer and in the base. And we then discharged the patient on hormone care because he was vitally stable and he had no other issues. So we did our first session of PRP and we discharged the patient. And we called him after 3 to 4 weeks to see the response and to go for the second session. Now, he was called after 3 weeks for his second session, and there was a very dramatic improvement, very, very good, excellent improvement in his. In the lesion, the ulcer size was reduced. There were the induration. It was only minimal, very minimal induration was present now. The inflammation, the active margins, they were almost gone, and the weeping and oozing, it was also absent. These are the pictures which are after the second session of the platelet-rich plasma therapy. And as you can see, the wound is now healing. The ulcer is almost gone. It is in the healing phase. Then the patient followed with a third session, and then the patient he followed up 2 months after the third session. And as you can see, there was complete resolution of the lesion with only post-inflammatory hyperpigmentation. So let's discuss the case. A chronic non-healing ulcer, it's a major health problem, and its prevalence in the world ranges from 1.9 to 13.1%. Conventional treatment for non-healing ulcers includes wound cleansing, necrotic tissue debridement, prevention, diagnosis, and, if necessary, treatment of the infection, mechanical offloading, management of blood glucose levels, and local ulcer care with dressing applications. Platelet-rich plasma therapy has gained interest in recent years as a potential treatment for chronic wounds. What is it? It is a concentrated solution of autologous platelets, as you all know, growth factors, and cytokines. And its ability to stimulate tissue regeneration, angiogenesis, and inflammation modulation has been investigated in various medical fields, not only in dermatology, but in dentistry, orthopedics, and surgery. Several studies have reported the successful use of PRP in chronic wounds, including diabetic foot ulcers, venous leg ulcers, pressure ulcers, and surgical wounds. Now, this platelet-rich plasma therapy is being very commonly used in surgical setups in worldwide by the general surgeons for the management of non-healing ulcers, such as diabetic ulcers. But in dermatology, it has been, unfortunately, as Professor Mara pointed out, it has been restricted to aesthetic purposes only. The advantages and merits of PRP: it is easy, it is cost effective, and it is much more lasting compared to other standard treatments. It is, as it is autologous in nature, it's free from any communicable pathogens, and it is a safe treatment modality with very good clinical results. So there are certain references. I took out certain articles from the web and I studied them. And most of them were from the surgery department. but there are very few studies from clinical dermatologists. So this is something which is yet to be, it is a growing field in dermatology. Like I think there needs to be more research and more clinical studies to be done in clinical dermatology, because in surgery, in orthopedics, and in dentistry, this platelet plasma therapy has been implemented for the last many years. Now, this reference shows a study which was basically an observational study. And in this study, they basically took out the data from the previous studies, and they found out that, as you can see, from 42 potentially relevant full text articles, they went through 42 relevant full text articles regarding PRP therapy in wound care and non-healing ulcers. And they took out the data, and from 1056 participants, 488 participants, they received the control treatment, and 478 were treated with autologous PRP therapy. And the 478 patients which were treated with autologous PRP therapy, they showed remarkable improvement. So, according to the currently available literature, it is still unclear whether PRP therapy is efficient for the treatment, and we need more and more studies in this area. Now, the case number two. The case number two is of an 18-year-old unmarried female who was a student, and she recently moved from Qatar. She had no other known comorbids, and she presented to OPD with complaints of multiple patches of non-scarring hair loss for the last 6 years. And she was already diagnosed as a case of alopecia areata in Qatar. And according to her, it started as a solitary patch, and then it increased in number. That is, the number of patches they increased. And it was treated multiple times with intralesional and topical steroids in Qatar. And initially, it used to improve every time they gave the steroids, but it recurred, and whenever it recurred with increased intensity. So this is her picture when she presented to me in the dermatology OPD. Apart from these patches, there was a localized area of scarring as well, which she told me it occurred after intralesional steroid was injected into that area. So we gave her 3 shots of intramuscular triamcinolone, 1 month apart, and we just gave her topical tacrolimus because she was reluctant to apply topical steroids due to the scarring. And we just sent her them, and then there was very good improvement with those 3 shots of iron triamcinolone. But again, after the recovery, it recurred after a couple of months, and this time the progression was very rapid. And when she presented to us after 3 to 4 months, she was going into alopecia totalis. That means there was almost complete loss of hair from her scalp. She was very, very depressed, and I referred her to a psychologist. You can see when she presented to me, she's going into alopecia totalis. Almost 90% of her scalp hair are gone. So we got her baseline labs done, and all the baseline labs were within normal limits. Her HP was very good. It was 12.6 gram per deciliter at that time. And vitamin D3 level, thyroid profile, everything was normal. And so we placed her on oral cyclosporin, 100 mg twice daily with regular follow-ups and monitoring. Why didn't we put her on oral or systemic steroids? Because she blatantly refused to take any kinds of steroids in future. So we directly placed him on immunosuppressant therapy. We had to stop that cyclosporin therapy after 3 months because the patient hemoglobin, it was dropping. She came to us with pallor, lethargy, and when we did her, we got her blood complete count done. Her HP was now 8 gram per deciliter, and we stopped the cyclosporin therapy. Meanwhile, as her clinical, the alopecia totalis, it was not improving that much. Like After 3 months of cyclosporine therapy, only 4 to 5% of improvement was seen, which was not a very good sign. And patient at that time, due to depression and due to other factors, psychosocial impact, many other factors, the patient and the family, they refuse to take any systemic treatment thereon. That is that they refuse for the steroids, they refuse for any kind of immunosuppressant. The patient's mother is very anxious. She said that she's a young girl and I don't want to put her on any kind of immunosuppressant in future. Her HB is dropping. She's not she is going to have another medical complications. So they completely refused to take any kind of systemic treatment. So we had to do something for her as she was a young girl and unmarried student. And we went through available literature on alopecia areata, and then we came across several studies and similar case reports which showed promising results of platelet-rich plasma therapy in refractory cases of alopecia areata, which was going into totalis. Patient and our family was educated regarding this. We took them into confidence. We counseled them and we educated them regarding this procedure from an educated family. So they agreed and we told them about its safety and possible outcomes. She was put on iron supplements. We had to get her CBC within normal limits before starting this therapy because we had to take her own blood. So once her HB it returned to normal, her CBC count was normal, we planned to do monthly sessions of platelet-rich plasma therapy with microneedling. We did not inject this PRP. We applied this PRP along with microneedling technique. At that point, she had alopecia totalis going into universalis. What is universalis alopecia? That is loss of eyebrows, lashes, and almost the whole of the body hair. But as she was more concerned about the scalp hair and the eyebrows, so we stuck to this therapy. So when she came to us for the first session of PRP, that was around July 2022. This is her picture. These are her pictures taken with the consent of the patient. As you can see, there are almost no hair on the scalp. After 6 sessions, now with every successive sessions, we could see new baby hair coming. And the good thing was that with every successive session of PRP, the previous hair that were on, they strengthened, and they did not shed off. The previous hair, when they came, with every successive session, they strengthened. And after 6 sessions, she had a good amount of hair on her scalp. After 8 sessions, only a few patches were left. All this time, she was only applying topical tacrolimus. She was also taking calcium and vitamin D supplements as they were borderline low, whereas her mental health was remarkably improving. She was now a very happy, content, and satisfied young girl at this moment, and which also contributed to her the successful treatment because, as you know, alopecia areata goes into a vicious cycle as it increases with increasing stress. So after 12 monthly sessions, we stopped her microneedling because almost 95% of her scalp was covered. And then we did PRP, mesotherapy, that is, we injected the PRP, and we have been doing it 3 monthly. We did it 3 monthly for twice. This is a picture from this June 2024. As you can see, alhamdulillah, almost, or I should say, the whole of her scalp is covered with thick, strong hair, even better than before. And she did not have, as she's been off this treatment for the last 6 months, she has not had any recurrence. There has been no new patch. So let's discuss this case. Alopecia areata. It causes non-scarring alopecia through an autoimmune mechanism targeting the hair follicles. It has an unpredictable course with 34 to 50% of patients recovering within 1 year and 14 to 25% of patients progressing to alopecia totalis or alopecia universalis. Approximately 24.2% of patients with alopecia totalis or alopecia universalis reported hair regrowth greater than 90% over 10 years. So, a very low percentage of patients they get recovery. Alopecia totalis and universalis is a very poor prognostic sign. Treatment of alopecia areata is challenging, and hair loss may remit naturally, although spontaneous hair regrowth may take months to years. Traditional therapeutic modalities include corticosteroids, immunosuppressants, topical immunotherapy, light therapy. Several new treatments are under investigation, including IL-2 agonists, IL-17 inhibitors, abatacept, JAK inhibitors, and PRP. There are some references. Now, I would like to call Professor Mehra to shed some light on this subject. Thank you.
Thank you, Dr. Matia. Assalamu alaikum, everyone. Because some of our faculty members and our colleagues have joined us meanwhile. PRP is the emerging technology, and it is supposed to be the aesthetic procedure in dermatology. Otherwise, it is not an aesthetic one. And it is basically the use of an autologous preparation of plasma with concentrated platelets to stimulate the hair growth. It contains a variety of growth factors and cytokines to stimulate repair and regeneration of hair follicles. And other indications include wound repair, that the first case of our presentation was. And angiogenesis, again, it helps in wound repair as well as in the differentiation and the proliferation of adipose precursor cells. These are the other indications for platelet-rich plasma. Next. Okay, PRP actually consists of more than 20 growth factors secreted by platelets concentrated in the PRP, and hair growth is stimulated by all these growth factors. These growth factors bind to the corresponding receptors which are expressed by stem cells in hair follicle bulge and the surrounding tissue. The ligand binding give rise to anagen follicular unit, which is the growing phase of hair follicles and promoting hair growth. These growth factors initiate pathways causing angiogenesis and development of adnexial structures. Anagen-associated angiogenesis is linked to the vascular endothelial growth factor, which is secreted by keratinocytes located in the outer root sheath of and fibroblasts of hair follicles in dermal papilla. These are the references. Now, this was the case which was the study was conducted at the randomized double-blind placebo and active control half-head parallel group study to evaluate efficacy and safety of PRP in alopecia areata. Total 45 subjects were randomized to one of three groups: PRP, triamcinolone group, and placebo group. Like, one group was given PRP therapy, the other group was given triamcinolone, which is the corticosteroid, and the third one was treated with placebo. 3 treatments with 1 month interval were administered in each group. The subjects were evaluated at baseline, 2 months, 6 months, and 12 months. The results of study revealed that intralesional triamcinolone and PRP results were significant in hair regrowth in alopecia areata lesions compared with the placebo or to the baseline results. The results were sustained at 1 year follow-up in both groups, but PRP revealed significantly better dermatoscopy results than giving intralesional triamcinolone. The next study was, it was again randomized control trial study to investigate the efficacy and PRP in treating alopecia areata. Total 90 patients were enrolled with patchy alopecia areata, alopecia totalis, as well as alopecia universalis. And the ages were between 10 to 40 years. No therapy for at least 3 months prior to the study. Patients were randomized into 3 groups, 30 each. The first group was treated with topical minoxidil 5% twice daily, monotherapy. Second group was treated with PRP, 3 sessions every 4 weeks. And the third group was received topical penphenol as a placebo cream twice daily. Although both PRP and minoxidil 5% showed significant increase in hair growth, but the subjects in PRP group had significant decrease in short vellus hair, unlike with the minoxidil, and control who showed a significant increase in short vellus hair. That means they increased the growth of vellus hair, but they did not turn them into the terminal hair. That is the main point, that PRP give a good result. The patient underwent PRP therapy had better and earlier results compared with the minoxidil. And besides the minoxidil, the group with minoxidil therapy, the group with minoxidil therapy showed more vellus hair than the terminal hair, while PRP group showed less vellus hair, more terminal hair, and thick hair in the group. Apart from that, one thing that I would like to add over here, the patient is still in our follow-up and she is very happy. And this is not an exaggeration, because we used to feel that PRP results are exaggerated, but this is the real picture. And one more thing is that she doesn't have any hair on her body right now. That means it is not the spontaneous resolution, which is one of the course of the this alopecia universalis. So she is very happy that she doesn't have any hair on her body, and she is happy that she has good hair growth on her scalp. So now, any questions regarding this? I would like to add one more. So Dr. Marie wants to add something over here.
Yes, thank you, ma'am. One more thing I would like to add, that all the studies that ma'am have quoted and all the studies which I went through, most of them or all of them, I would say, they used PRP as the mesotherapy, like they injected the mesotherapy. Because in our case, we did most of our sessions, that is the 12 sessions, we did them with microneedling technique. So I think that is also something which we did for the, if not for the first time, but it is very rare. Most of the cases, most of the studies which I went through, they all injected the PRP into the scalp. Whereas we achieved these results with microneedling therapy alone, and we're just doing the mesotherapy for maintenance purposes now. Thank you. Any questions?
Apart from that, alopecia areata is, as we all know, that it is a condition of autoimmune disease. So the minoxidil or other therapies need to be on maintenance therapy. And the first case I would like to consider, the first case initially. There are many patients that we have with these type of non-healing ulcers, especially in diabetic patients, and go to the initially they are the patients of internal medicine doctors or physicians, internists, but later on they are sent to the dermatologist. So if we have any such patient, because these lesions, these conditions are tried with everything. What PRP used to do is it increases the growth factors that are unable to reach in these areas, especially in patients with diabetes because of vascular abnormalities and neurological abnormalities. So we actually directly inject the required growth factors and all the nutritional material into the lesion to heal as early as possible. So it is my humble request to internists, specialists, supervisors to work on it, to give your postgraduate trainees this task to work on PRP therapy, excuse me, especially for wound healing. Alopecia areata is reserved for the dermatologist, because most of these patients go to dermatologists. I would like to request my humble request to all the dermatologist supervisors as well to give your postgraduate trainees this task, especially for research purpose, to work on it. It is easy. It is what should I say? It is economical for the patient for PRP in wound healing, especially. Now, any question regarding this in the audience? Yes, sir. Yes. Uh, if we consider it anti-nuclear antibody or any profile like that, alopecia areata may be associated vessely, but we work for it or evaluate the patient for SLE if other symptoms of SLE are also present. She was evaluated for autoimmune conditions. Her previous investigations were done from some other hospital setup. They did she came from Qatar and she had almost all investigations done over there.
All her work was done. When she came to us, she was already, it was already a diagnosis of exclusion, basically.
Yes. Yes. Yes.
Yes, there is.
Yes, we cannot say that any autoimmune condition, we initially tell our patient that even if you don't get this problem for say 20 years, but still we cannot say that you are you are cured. So any such condition, we tell our patient this can recur anytime. But this is the safer modality and treatment modality compared with the autoimmunosuppressants or any other such treatments. No, no, we don't give any continuous treatment or steroids because she's happy with her life. And one more thing is that whenever a patient is psychologically stable, she will go into the improvement or spontaneous resolution on her. So she may develop a spontaneous resolution and she may develop body hair later on in her life.
Yes, Dr. Omera.
Yes, Dr. Naira, you have a question? Hello?
Assalamu alaikum. Can you hear me?
Yes, yes, we can hear you. Alaikum assalam.
First of all, I must like to congratulate Dr. Humaira and Dr. Madia for these wonderful cases and the wonderful results, and especially in the case 2. And I would like to add, do we need to keep pyoderma gangrenosum in case 1? And do you think are there any chances of relapse in case 2? And what do you think PRP should be reserved for the for after all the treatment have failed, or we do need to consider this as first line treatment, though it has not been mentioned in any literature as first line treatment? So these are my 3 questions.
Okay, so the first question is first question was that the spontaneous resolution can occur and the recurrence can also occur in these patients. So we also already
Do we
discussed
need
that.
to give pyoderma gangrenosum?
It is not the
Because that is
pyoderma
basically another
gangrenosum, Dr.
diagnosis
Mera.
of exclusion.
It is the epthyma
Where they
gangrenosum.
make a differential diagnosis of any ulcer.
Okay, non-healing ulcer, but biopsy did not favor any findings of pyoderma gangrenosum.
But we can keep that in.
Yes, we can. It can be kept in diagnosis. But there was only one ulcer, and it did not increase to that much size. But yes, it can be kept in the differential diagnosis. And what was the last question?
Second was the chances of relapse in alopecia areata treated
Yes,
with
yes.
PRP.
It is. And one more thing that you ask is, it is the first line therapy. No, it is not the first line therapy. But in case of neurotropic ulcers or in case of diabetic ulcers, we know that conventional
And
therapies are
refractory
not going to
cases.
work
So
very
this should be
effectively.
kept for refractory cases of alopecia
Yes.
areata.
Yes, yes.
Ma'am,
I'm asking about the refractory cases. We
refractory
should.
cases and cases in which, such as in this patient, where the parents and the girl, they refuse to take any kind of systemic treatment because this is the area, this is the era of the social media, and everybody is going through Google. The family was educated. They came from abroad. They had knowledge of side effects of steroids and immunosuppressants. So in such cases, it's very difficult to counsel the patients and their families. So I think it is, and the studies, the case reports which I have mentioned in the references, if you go through them, there is mentioned that platelet-rich plasma therapy has been used in the past as an adjuvant therapy, but now we can say that it can be used as a monotherapy or a standard therapy alone in such difficult cases, recalcitrant cases, or in which the patients are reluctant to take any other kinds of medications.
One more thing I would like to add, when I was searching the literature, they are also trying to work in the platelet-rich plasma therapy in cicatricial alopecia, the diseases with cicatricial alopecia, to halt the inflammatory process which is going on in such conditions. So, cicatricial alopecia is also an indication for, or the diseases with cicatricial alopecia are also an indication for this PRP therapy. Any other
Okay,
question?
thank you very much. Thank you.
Dr. Najia.
Assalamu alaikum.
Alaikum assalam.
I would like to appreciate Dr. Humaira and Dr. Madiha for presenting such nice cases and bringing up this important topic of PRP, which we are all using very conveniently these days and getting variable results in different cases. For the sake of trainees who are our main audience, I would just like to comment that before proceeding to PRP, we should make all possible efforts to establish the diagnosis. Because in the first case, we did not get a diagnosis actually, and we just treated it with PRP. It's a good luck that it healed well and showed good results. But at least for the sake of trainees, we should give them some workup. Like these tests were done to establish the diagnosis. And I think if one biopsy is inconclusive, we could have repeated it. Maybe the section was not representative, or he had already received some anti-leishmanial treatment. So I don't know what was the baseline biopsy, if any biopsy was done before giving any glucantime injections. So I think the diagnostic work should have been a little more extensive. And regarding the second case, it's not actually regarding the second case, it's regarding PRP. I would like the presenters to tell us some details about the process they followed for PRP, because when we are discussing PRP, we should give some details about what procedure was followed, how many revolutions per minute, single spin, double spin, open procedure or closed procedures. So I think that would enlighten the trainees as well.
Okay, she wanted the details of how the PRP was made and at what settings and everything.
Well, I think that will take more time to discuss all these things, because these things are already this. I think what I think is not the forum for details of this thing. These things are taught and learned at the centers for the students.
Yeah, definitely.
If we tell them each and everything over here, Dr. Najia, then we will take a little more time. So
Yeah,
I think.
sorry, but I beg to differ, because when we are discussing a procedure without standardizing it, we cannot comment on its efficacy. So that's fine that you're saying that it will take more time. But I think if there was one slide which showed the procedure, because most of the research articles, everything is standardized. Even the machine they use, the tubes they use, everything is stated. So without that, we cannot say the standardization.
Okay. Any other question? Dr. Rubina. She was the first. Yes, Dr. Rubina.
Interesting to know that if there is any role of intralesional PRP in oral lichen planus. Up till now, anything if you know about?
The literature is still under investigation for the inflammatory conditions related to skin and mucous membrane. But I am not sure about any results regarding the oral lichen planus in PRP. Ji, Dr. Dr. Mera. Dr. Mera.
Hello, I'm Dr. Faria.
Dr. Mera, I have a question. Is there any role of PRP in pediatric age group, especially in children with alopecia areata in children?
Yes, the research article or the study that I shared over here, the age group was between 10 to 40 years. So I think this is the best safe treatment for these patients.
इसमें आ नहीं रही आवाज नहीं. Hello, hello.
Hello, can you hear me?
Dr. Humera, we as surgeons, we deal with open wounds lot of time. There are few wounds in whom we provide an opportunity to the patient to heal by secondary intervention if the defect is small. If we try to eradicate infection, giving antibiotic at the same time, then in these cases, is there any role of doing PRP? And similarly, if it's a difficult wound like a case of burst abdomen, definitely they need resuturing, we give IV antibiotic, and at the same time trying PRP. What is the role?
The literature says that surgeons, especially, I went through the literature and it was given in it. They prophylactically give any such condition. They prophylactically inject PRP in the wound. So this is
Before stitching, after the surgery.
After surgery, at the time of surgery, at the time of stitching, they give PRP to facilitate or to enhance the wound healing rather than waiting for wound descent or rupture or infection that leads to it.
There must be some criteria for that. Like we cannot give it to each and every patient.
No, there must be some criteria, and surgeons know much better than we do. Because when I went through the literature, it was written there that they used to give. Yes, there is risk of wound or any patient who is like obese patient who have this risk or chance of wound descent or rupture or anything like that. They used to give to enhance the surgery. I'm sorry, Dr. Faria. Yes, now you can ask.
Yes,
Hello?
this is Dr. Reema Mirza. Can I add something?
Yes, sure, Dr. Imran.
Assalamu alaikum. This is Dr. Reema Mirza from Civil Hospital, Karachi. And I must congratulate Madiha and Professor Humera for the presentation of these nice cases. And alopecia areata, very resistant to treatment. And this is a very good presentation to give us an idea that something else also can be tried in the last resort in refractory cases. I want to ask one question that the hair that growed or that the scalp hair regrowed. Like in what regarding you said the patient went into alopecia universalis. So regarding the eyebrows and eyelashes, was there any response on that also?
In that eyebrows, we did microneedling on the eyebrows as well.
Yes.
Assalamualaikum, Dr. Reema. We did the microneedling on eyebrows as well, as I you pointed out that she just wanted some localized procedure. She did not want her, she was okay about her body hair, but she was concerned about the eyelashes and eyebrows. The eyelashes, they're still, if you can see the pictures closely, I can share, but if you can go through the presentation, which will be shared lately, the eyelashes, they're still not there, but the eyebrows, they grew back because we did microneedling on the eyebrows as well and on the scalp. So this is one of the proofs that the hair did not, there was no spontaneous resolution. There can be spontaneous resolution along with that, but it was unlikely as she does not have any of the body hair and the eyelashes still.
Okay.
And
see, alopecia, yeah, it's something very distressing for the patient if the patient is not getting response from the treatment. And also, when the
But
patient is being given the
she's
systemic
not, she refused
therapies.
to take any kinds of other treatment. Now
Yeah,
she's happy with the
yeah,
results, and she still says that if in future, if any relapse occurs, she's ready for it. We've counseled her for any kind of relapse
yeah.
in future, and she's still adamant that she's not going to take any kind of immunosuppressants, systemic immunosuppressants or steroids.
Yeah, and in fact, immunosuppressants, their results are also not confirmed that we'll get response with that. And in majority of the cases, like when you stop those immunosuppressants, again there's a relapse, and there are so
Yes.
many side effects. So
And she
PRP,
went
yes,
to one.
it should be taken as
She
one of the options for treatment,
yes, and
especially in these categories.
I would like to address Verdi ma'am, Dr. Nadia Umar. I would like to say one thing that as she pointed out that for the sake of postgraduate training, we should have had done more of the workup. Actually, the title or the if you can see the title of our presentation was that we would like to point out or we'd like to emphasize on the fact that these procedures which have been compartmentalized or which have been used, which have been restricted to the aesthetic purposes only in our dermatology, they can be used much more often and frequently in the clinical setup or in the clinical dermatology practice as well. So that was the basic crux and that was the basic idea of presenting these two cases. It was not actually to teach about the PRV procedure, but yes, ma'am, you're right. I should have added a bit more about in detail about the procedures as well. And one more thing was that when we go for aesthetic PRP, like when patients come to us for androgenetic alopecia or any other hair fall, diffuse hair fall, telogenic fluvium, or female pattern hair loss, we as clinical dermatologists, we do the whole workup for that prior to starting any treatment. But in many setups, in aesthetic setups, and even clinics where dermatologists are doing their private practice, this is not the case. They just can come and they demand to get the PRP done. So when we are doing PRP in aesthetic purposes without doing any workup, which is the case going on, why can't we just go for PRP in an indoor setup where we have the facility, where the patient is lying in the ward and the workup is going on and we just give it a shot? Why not? I think we should not wait for the whole workup to be done, the whole diseases to be excluded. We can go for this therapy if we have the facility as a symptomatic treatment. I think this justifies it.
Yes, for the symptomatic improvement in hair growth, because the alopecia areata causes depressive disorders in these patients, psychological problems in these patients. So once we improve the patient psychologically, we can give a boost to the immunity or the internal immunity abnormality in these patients, and that may result in spontaneous resolution. So she's right that we can give as first line therapy while the workup is going on, and when we get the actual cause of disease, we can treat the cause as well. Yes.
Is there any role of PRP for the repigmentation or scar line, scar repigmentation? Just like nurses, if you have a wound infection, उसके बाद scar
We do PRP for scars.
is there any role of PRP?
Yes, we do. PRP, as it has been commonly used in cosmetology and aesthetic practice for skin rejuvenation and for treatment of acne scars. And if it's being used in treatment of acne scars, it can be used in all kinds of scars because it causes skin rejuvenation. So we use it. People come to us they even come with the striae distensi, the striae gravidarum. They come to us, they present after their delivery, and we do PRP with microneedling on those stria as well. Yes, and not the hirsutism, the androgenic alopecia. We go for that. We do, but as an adjuvant treatment, never as a monotherapy, because PCOS it's a clinical it's a clinical disorder, and it has to be treated. It has to be worked up and treated. I think you would like to.
Thank you. सर को बुलाना था क्लोजिंग के लिए जरा कॉल करके पूछो हाँ I would like to invite my seniors and the Rue Rama of CPC Dermatology, Dr. Humera, for your closing remarks. Dr. Humera Talat, can you give some input?
Yes,
And
thank you, Dr. Humera. And it was a wonderful presentation. And I would like to invite other hospitals also from this forum to please come forward and bring your important cases. We must have, we must bring our important cases treated clinically or aesthetically forward for our juniors and to give them a good message. So I would like to invite others also, other hospital like Hamdard Medical University and Jinnah Hospital, because Rabia, Fazaiya Civil Hospital, PNS Shifa, Aga Khan, Daw International Medical College, we have been doing this for the past 2 years. So other hospitals must come forward and play their role, and they should put their efforts, and they should show their efforts to us. Thank you so much.
Thank you so much, Dr. Mera. Sir. Ma'am. Uh, Dr. Sadia Tabassum, ma'am, would you like to give your input regarding our case presentations? Dr. Sadia Tabassum, I think she's not here. Dr. Sadia is not here, I think. So, no, Dr. Sadia nahi hai.
Dr. Sadia Tabassum, I think she's not there. Thank you very much, everyone. I would like to close this session, but at the end, I like to invite the most senior person in our faculty, Dr. Ruxana Abdul Sattar. Almost everyone knows her. She is the internist. She is the professor from JPMC. So I would like to invite her for her closing remarks for today's. And wherever she goes, that that event is blessed by her kindness. Thank you, ma'am.
Thank you very much. Assalamu alaikum. And it's really a big pleasure that she has given such remarks about me. It is really, really good, and we all should go for such sessions. It is a very pleasant and interactive session, and we all learn from such sort of sessions. And every specialty should arrange such session like Humera. I'm thankful to each one of you, and Dr. Humera and Dr. Madhya especially. Thanks a lot. Have a good time.
Thank you, madam. Thank you for blessed remarks. Thank you very much. Now, at the end, I would like to thank Pakistan Association of Dermatologists who gave this opportunity to us for this forum. And just like Dr. Mera Talat said, other institutions should come forward, and they should also take their cases, because in this way we not only learn, but we refresh our memories and we refresh our studies and all these things and knowledge we share. Thank you very much, everyone. And at the end, I would like to thank Brooks Pharma, their participation, their support in this event every time. Thank you very much. Thank you, everyone. Thank you.